Hi, I'm Kristen Cohen. The title of my project is Implementation of a Screening, Brief Intervention, and Referral to Treatment, or SBIRT, program for alcohol use during pregnancy. My team members are Dr. Tracy Vitale and Dr. Vanessa Parisi. Alcohol use during pregnancy is associated with various risks for the developing fetus, including the spectrum of physical, behavioral, and emotional sequelae commonly termed fetal alcohol spectrum disorder, or FASD. Recent studies suggest that FASD is considerably more common than previously thought, affecting as many as 10% of children in the United States. There is no known amount or type of alcohol that's considered safe for the developing fetus at any time during pregnancy. So for this reason, it's recommended that pregnant patients abstain from drinking alcohol. However, approximately 1 in 9 women drinks alcohol during pregnancy in the United States. Professional organizations recommend that all pregnant patients be screened for alcohol use at the beginning of pregnancy, but studies indicate that screening is often either not performed correctly or not done at all. Furthermore, many patients report that they don't receive adequate guidance from clinicians regarding alcohol use during pregnancy. What this means is that many patients remain uneducated about the risks of alcohol on the developing fetus, and many patients continue to drink during pregnancy. Screening, brief intervention, and referral to treatment, or SBIRT, is a well-established public health approach to delivering early screening and intervention services in the primary care setting to patients at risk for substance use disorders, including pregnant patients. The 3 phases of SBIRT are completed sequentially, all within the same patient interaction. First, the screening, then for patients who score at risk for the behavior, a brief intervention is performed using a patient-centered motivational interviewing technique. For patients who score at highest risk or at the clinician's discretion, a referral to outside treatment is provided so that they may receive more intensive care from a specialty provider. The screening tool that I selected for this project is the TACE tool, which is validated for use among pregnant patients to identify those at risk for an alcohol-exposed pregnancy. TACE is an acronym for the 4 questions in the tool: tolerance, annoyance, cut down, and eye-opener. A score of 2 or greater indicates the patient is at risk for alcohol use and should receive a brief intervention. This was a quality improvement project with a pre-post quasi-experimental design with the goal of implementing the SBIRT process to identify first trimester pregnant patients at risk for alcohol use. I conducted the project at a privately owned suburban OB/GYN office in northern New Jersey that had no consistent approach to alcohol screening or to providing guidance regarding alcohol use during pregnancy. The study population was a convenient sample of 2 physicians, 1 nurse practitioner, and 3 medical assistants, all of whom were employed at the office. I trained the office staff on the use of SBIRT and the TA screening tool with the intention of screening first trimester patients over an 8-week implementation period. Screen-positive patients were to receive an immediate brief intervention and or referral to treatment. The staff filled out a post-implementation SurveyMonkey questionnaire, and I conducted retrospective chart reviews to tally screening results and pre-implementation data. My measurable outcomes were the number of eligible patients screened, the number of patients who screened positive, and the number of brief interventions and referrals to treatment performed. I also compared the number of at-risk women identified pre-SBIRT implementation over the same 8-week time period in 2019 versus post-SBIRT implementation, and collected feedback from staff. What I found was that 35 out of 55 first trimester patients were screened for alcohol use, which is 64% of patients. Of these 35, 9, or 26%, screened at risk for an alcohol-exposed pregnancy. 100% of these patients received an immediate brief intervention, and no patients required a referral to treatment. Prior to SBIRT, in 2019, 0 patients were identified by staff as being at risk for an alcohol-exposed pregnancy. Based on staff feedback, 100% of staff members thought that SBIRT was effective at identifying pregnant women at risk for alcohol use, and 66% thought their office should continue to use SBIRT for alcohol use. These results show that implementation of SBIRT resulted in an increased identification of pregnant patients at risk for an alcohol-exposed pregnancy. The inherent value in a screening tool is that its use facilitates discussions about alcohol abstinence recommendations during pregnancy. SBIRT implementation is low cost and easy and quick to perform, and it has the high potential benefit of reducing the incidence of FASD. SBIRT is evidence-based care that improves maternal and fetal safety as well as pregnancy outcomes. The next steps for this project are to hardwire and streamline the process to better incorporate SBIRT into the office workflow, as well as expanding screenings to include 2nd and 3rd trimester patients. My team member, Dr. Parisi, and I also plan to apply this implementation experience in an effort to begin SBIRT programs in other northern New Jersey OB/GYN offices. My email address is here. Please be in touch if you have any questions. Thank you for listening.